Good morning, class. Today's lecture is an important one on neoplasia. Of course, malignant ones being causing cancer. And so all of you, you're going to deal with this your professional lives, your personal life. It's the second biggest killer in the US. So very important lecture, terms you need to understand, processes, and let's get started. Right, so neoplasia. You're going to see these are going to be certain cells have genetic changes that cause them to really lose control of dividing. So they divide uncontrollably. And these cells are damaged cells, they're not normal cells. And so we'll talk about benign is the one you want to hear about, and then malignant is when it's actually can spread. In cancer, wonder why it's similar to the zodiac sign for the crab. It's named that because if you look at cancers, they'll sometimes have legs that come out as they spread into the tissue, kind of like a crab. So that's where that came from. So let's really pay attention to this definition here. So it's going to be heritably altered. So it's something in the genetics that has changed. Relatively autonomous means it kind of can live on its own, not completely. It still responds to hormones in your body and uses your energy and needs your oxygen. But it's a new growth of cells from some altered cell. And just to give you bottom line now, I actually need a bunch of mutations. It's not one mutation that cells cancerous. So it kind of ratchets it up as these cells become more successful in being able to spread and survive and outcompete the other cells. So heritably altered, relatively autonomous, new growth of cells is a neoplasia. A tumor is a general term. It doesn't have to be cancerous at all. I show a couple examples here. Some ovarian ones can get pounds, huge, not even noticed in some patients. So benign. Benign is what you want to hear, as I said. It means it's usually localized. It's not going to spread. It can grow, but it's usually encapsulated, and it's not invading adjacent tissues and traveling to other places in your body. Malignant, a malignancy means it can spread. And we'll see invasion is spreading to your neighbors, and then it can even metastasize or move in your bloodstream or lymphatic system to distant places and take up hold and start growing there. And when it's malignant, we talk about when it's spreading, that's when we call it cancer. But a benign neoplasm could be just a mole or a lump in your breast that's not cancerous. It's just benign, and it can grow very slowly, or it can grow quicker, but it's not you're not in danger of it spreading. This shows a picture here of a bone, looking at a tibia there, and you can see a benign tumor is contained within the bone, with a malignant one is starting to, it's eaten its way through the periosteum of the bone, and now it can spread. So those terms, invasion means that these cells are spreading into the adjacent tissue. And in many cases, they develop the ability to break through the connective tissue, to make enzymes to dissolve it in order to allow them to spread. And when you hear metastasize, that means it's actually moving in a distant place. So this picture here, breast cancer, and things that have been studied so well, we know where they're going, typically, and they can surprise you. But when you look at the breast, cancer, we know we look in the axial or armpit region, look at those lymph nodes. And we know it's going to spread easily to the lungs and the liver or to bone. And it finds its way there through your fluids, so through the bloodstream or through the lymphatic fluid that also is going to carry your fluids throughout. And so looking at benign versus malignant, just kind of a helpful chart. You can see the growth rates. A malignancy is often rapid growth rates. And a benign, you often have a kind of a capsule around it, surrounding it. You look at the border of a malignant, feeling a lump and it feels irregular. That means it's spreading out, and probably not benign. Benign does not metastasize, right? We talk about differentiation, talk more about that. We'll see that malignant cells look weird. They really change quite a bit, as it were. A benign, it looks more similar to the original cells. And when you look at the cells themselves, the cytology, a pathologist looks at it, you'll see malignant cells will have large nuclei, big nucleoli. They are just dividing very rapidly and making proteins rapidly. So here, oma, a lipoma will be a tumor in fats, right? But you got to be careful a little bit because a hematoma is just a pool of blood, right? And a granuloma, we talked about in the last lecture, is a kind of an encapsulation of an inflammatory response. So, you know, hematoma has nothing to do with cancer, but most things, carcinoma, lipoma, osteoma, all these things, we're talking about a tumor. So the two main types of neoplasms here, carcinoma is the most common, and that comes from epithelial tissues. So skin, coatings, glands, that's going to be the origination. So breast cancer, usually, you see adeno means from gland. So you see adenocarcinoma, it's originating in a gland. So that can happen in the skin, the breast, the colon will be glands in the colon that the cells that cause the cancer first originated. And just so you know, so a cancer, maybe you come late and you find cancer in your brain, your bone, your liver, your lung, everywhere. They can take a look carefully at those cells and they can tell where they came from usually. They're gonna have signatures that say, oh, look at that liver cancer, we took a biopsy, those cells came from the colon originally. Remember the blood supply, your hepatic portal system, takes all the blood from your intestines and it goes into the liver through that portal system. So you can see how it could have traveled. And the liver is a big sponge, so you can imagine the blood is going to just percolate through. It's easy for cells that have broken off from the colon to lodge themselves in the liver and begin growth. So they can look at your cancer anywhere in your body, and they can usually map it back to where it came from, and that's what your diagnosis is, that original cancer. Even though it may kill you in the brain, it originally came from your colon or something like that. So carcinoma coming from epithelial tissues, and then a sarcoma is going to come from more connective tissue, bone, muscle, cartilage, and that's not as common as a carcinoma. Yeah, you can look at some terms, these would be familiar. So again, you definitely got to know when you see adeno means from glands. Adipose tissue, a lipoma, those would be, sometimes people get round things in their fats, little solid things. Osteoma, chondroma, bone, cartilage. Yeah. And these are malignant ones. These are types of cancers. So you're familiar with skin cancer. You can have a basal cell or squamous cell. The worst one is melanoma. The melanocytes are actually become cancerous. And that, although it's the rarest kind of skin cancer, is the most deadly. It's absolutely. Yeah, breast cancer will be adenocarcinoma of the breast. Sure, prostate's a big one. And then, of course, you're all familiar with leukemia. It's going to be cancer in the bone marrow, or lymphoma, which is similar, but that's in lymphoid tissue. It could be anywhere in your body. And then sarcoma, remember, is going to be in connective tissue, so like bone, osteosarcoma, fibrosarcoma. Yeah, and a glioma will be a glial cell in your brain. So it's got to be familiar. These are things that you'll commonly encounter. You probably have already encountered in your life also, these various kinds of cancers, and the names you shouldn't have to memorize it. Should bring you back when you think, oh, adeno, that's going to be from glands. Lipoma is going to mean fat. So what are the big killers? Well, first of all, when you look at the variables involved with cancer and its prognosis too, what site is it developing in? Pancreatic cancer, very low survival rates. Skin cancer, often just taken care of in the doctor's office, and it's more of an annoyance, right? Your gender, so definitely sexes, of course. Breast cancer, very rare in males, although it happens. Prostate cancer, not going to find it in a female. And age, you look at prostate cancer is a disease of the elderly, and then testicular cancer is a disease of young men, 20s or so. So when you're looking at these variables, you can see the ones that make sense. All right, what are the big killers I've covered over with my face here, but the big ones are breast, lung, and prostate are just about right in the same ballpark. So prostate among men, breast among women, lung cancer, either sex. Yeah, and looking at those, lung cancer is the deadliest of those. And then colon cancer takes a step down, then bladder cancer, melanoma, yep, lymphoma, thyroid, leukemia comes down there. Yeah, and notice it doesn't have skin cancer is actually the most common, but these are based on hospitalizations, and so that skin cancer is often taken care of just in the doctor's office. Yeah, so breast, lung, prostate, up there. And this just shows it in a chart form here. And overall, right now, heart disease is #1 killer in the US, but cancer is #2. And it will probably overtake heart disease. And it's a disease of the aging population. You'll see cancers take a long time to develop. And so as you get older, there's just more and more chance for more of those mutations to ratchet up. So it's a disease of the old, although infants can have cancer too. Take a look at this. It jumps out at me as lung, breast, other, prostate. So looking at frequency and how bad is this? How bad are the different cancers? You can see lung cancer, we're talking about 5-year survival rates. Wow, really bad. As opposed to prostate cancer, 99%. Yeah. Absolutely. It's going to depend on many factors, but they come up with these survival rates based on data from real patients, and they're all reported, they're analyzed, and we'll talk later about staging cancers, but you can give a patient a good guess or prognosis of their what's going to happen. People can surprise you, but there's a probability of survival, definitely. So prevention. You can do things to prevent cancers. Don't stand around radiation. Don't get in the sun, especially if you're fair-skinned. Don't eat charred meat. Stay away from various chemicals that are known to be carcinogens, which are cancer-causing substances. And especially screening. Screening is huge. This is the idea: you go in and you take a look. And now remember, screening, you've already have the cancer if they're going to detect it, but the earlier the better. Big difference in some cancers. You get it early, colon cancer, easily removed before it becomes malignant. Indeed. And then for screening, some of the issues are that, we'll talk about it. Some of screening is expensive if you don't have insurance. No one's going to get a colonoscopy and pay out of pocket. I mean, it's thousands of dollars, right? And then so there's other thing of just colonoscopy. It's going to catch colon cancer early when it's easily treatable. But the problem is it's a pain in the butt. I didn't mean to do that. But you've got to take this horrid tasting fluid that makes you just go to the bathroom all night to clean out that colon, so they got a good view when they stick that camera out there. So you see a lot of hesitance to get it, even though they may have insurance and it's completely covered. Yeah, and looking at colon. There's now, as a colonoscopy, probably in the future, it's going to be much rare to get that, because you can do a fecal occult test. You can just look at a fecal sample and see if as it's come down, it's going to take off cells from the colon, and you can scan for some abnormalities. I want to go to the dentist. I love that they They check for oral cancer, especially if you chew tobacco, very common in the gums there. And then, yeah, blood tests for prostate. You can have a prostate exam, and they can feel in there, or get a blood test, and they look for this PSA, this prostate-specific antigen, much easier. So in the future, screenings will get better and better at it. More of it will be molecular instead of invasive. So if they're cheaper, available, we're going to catch more cancers early. And the Pap test, too, wonderful, saves so many lives from cervical cancer just by regularly getting that done. So I'll talk about that age difference. You can see in the elderly, cancers pop up. For one thing, as I mentioned before, genetically, once you're elderly, you can't increase your fitness by having any more kids. So there's very little selection against genetic diseases that pop up after childbirth for that. The second reason is simply age. You're going to get more mutations. They're going to accumulate. And mutations to cause cancer, they need to get one after another. Sometimes a series of 10 different mutations have to take place before it's actually cancerous. You can see cancer of the young, cancer of the retina, kinds of bone cancer, testicular cancer found younger age, and cervical cancer than something like prostate or breast cancer. So this disease is so it's not an infectious organism. It's your own cells. It's your genes. And because we live a long time, we're going to accumulate mutations. It just happens. When your cells divide, mistakes happen. You're exposed to exogenous radiation and chemicals, and even some viruses that can cause disruption of your genome. And normally, when you have these kind of these mutations, normally your cells check your DNA. There's a proofreading that happens, and a repair can even happen. And if you can't repair it, the cell is marked for apoptosis, cell death. That's cool. You get rid of those cells, you get a sunburn, and then those cells go through apoptosis, they die, you shed that skin to help protect against that. We tan because we put out melanin to protect the lower levels from UV light. But what's insidious is when you have mutations in the mechanism that's supposed to proofread or stop cell division. So you're screwing around with that machinery. And so you can see if you do that, if you screw up the editor, the proofreader, you're gonna get all these errors coming in, aren't you? And so that's the key there. And we'll also see some viruses with the way they work is they insert their DNA into your DNA. And if they put some kind of signal in where there's a promoter in your genome, it causes cell division, or they insert their DNA and they screw up your editing. So you can see when you're screwing up the DNA, if you get it in the wrong spot, you're going to have cells that are immortal or divide constantly or don't listen when they're supposed to kill themselves. Yeah, so you get mutations and then they're allowed to continue. The cells aren't killed, so you end up with these clonal varieties of cells that have these mutations. Yeah, clone. And so you get this defect, and if it it makes it through and it's not destroyed, you don't edit that out, then you've got a clonal lineage that has this error. And over time, additional errors can be introduced, and you start, like I say, ratcheting up these issues. So the term you hear something as carcinogenic means cancer causing. And when you look at cells, ask the question here, I kind of answered it already, but where would the mutations happen in a cell, in your DNA, in order to cause cells to become cancerous? I'm sure you have some ideas. Here they are. Yes. So all of a sudden, you've a cell has a cell cycle, right? Has a resting period, just usually most of the time, and then there's a mitotic division. There's times when it divides. And if you go in there and you cause a cell to divide constantly, it's going to increase in numbers. If you tell it not to kill itself or ignore those signals, you have cells that just hang around, and there's more and more of those. Respond to growth signals. Don't listen when there's growth inhibitory signals. Often a tumor cells will grow to fill in an area of injury, and then they stop. It's called contact inhibition. When they feel their neighbors, they're done, right? But if you have mutations where they don't stop, these cells just keep growing, even though they're supposed to stop. And then insidiously, later on, if you get cells that figure out that they make enzymes that can break down the connective tissue, it allows them to move. And then you can have cells that encourage blood vessel growth, angiogenesis, blood vessel growth. Then they feed themselves, they can grow faster. Because a lot of tumors, they grow so fast that it actually slows their own growth. Because for an active tissue, it needs a lot of blood vessels, capillaries to feed it, right? But the cells grow so quickly, it ends up in this mass where then the growth is really slowed. And often tumors depend on glycolysis more than aerobic respiration. So one way to detect tumors is you can look for those glycolic enzymes. And they're going to be especially expressed in tumor cells because they have such low vascularization that they don't get much oxygen, so they've got to do glycolysis. So anything that's going to cause angiogenic factors that make you grow blood vessels is going to make that cancer cell thrive. And then your cancerous cells should be recognized by your immune system. So anything they can do to kind of hide from that is going to be a benefit to them being successful. Yeah, like I say, using glycolysis because they're not getting much oxygen, and immortality. Cells are supposed to have a lifespan, but if they don't die, they're going to keep building up. All right, so this gives you an idea of what makes a cancer cell successful. And it's really like evolution, natural selection. You're going to have some of these, maybe they increase the rate of mitosis, but then they can't do these other things. And so, so they end up being destroyed. But if you have all of these factors, it makes you successful. It makes you spread. And this is what might kill you. It's strange thinking about your own cells, like trying to kill you. And they have no mind. They're not trying anything. It's just that these cells are an environment and they just behave how the genes tell them to. And so they just divide or spread because those are the successful variants. There's millions of other cells that have mutations that don't do that, but you have a population that gets these characteristics and it will spread and it will kill you. And so really it's so rare for this to happen. There's so many mutations happen that don't lead to cancer. It's got to be a mutation just in the right spot that's controlling some kind of proofreading or some kind of control of cell division. But there's actually 99% of your DNA is junk. It's just a bunch of, right? It's a bunch of repeating letters. Mutations in there do nothing, right? Some mutations are right in the middle of a gene, but as you know, you can have several different triplets, right? ACG, AC, something like that. They can code for the same amino acid. And so these are silent mutations that don't do anything, right? Or even if you change one amino acid, it sometimes doesn't change. So mutations that they've got to be, there's so many happen, it's just got to be bad luck to get one just where it's going to influence the genes that cause cancerous behavior. And normally you have repair mechanisms that proofread the DNA and they should fix it. That's got to go wrong. And you're going to find out here, I'm going to talk more about, it takes several successive mutations to cause a successful cancer. It's not one mutation, bam, cancerous. That's why you quit smoking. You know, it can actually really prolong your life. But if you continue, you're assaulting those cells again and again with the carcinogenic chemicals, and it's more likely those mutations are going to continue to build in those cells. And you know, some cancers are heritable, at least in part. And so when you see familial cancer, you're often born with already the first mutation starting. So you're likely to get the cancer at a younger age, or more likely to get it. You still may never get it, even though you've got the genes for it, because it's, again, mutation is a random process. So these neoplasms, these tumors, they do behave like a parasite. They grow, they steal your nutrients, they steal your oxygen, but they're not a foreign material. They still are your cells, so they still respond to hormones in your body. Yeah, and as long as they grow and they don't start digesting through their boundaries and invading adjacent tissues, it's still benign. But once they start getting these characteristics that allow them to be successful, then they can spread and they can start growing your bones, your brain, and everywhere. Yeah. So indeed, what you're doing is you're getting a mutation in a gene. And it's most often in genes that control the cell cycle. And so you get cells dividing way too rapidly. Now, oncology is the study of cancer, onco. And so an oncogene is a gene that we have found that is going to cause cancer. And so there's hundreds and hundreds of oncogenes that have been identified. A proto-oncogene means that's an area where if you get a mutation, it can turn into an oncogene, and that can cause cancer. Sure, you only need one allele. Sometimes it doesn't have to be both alleles to cause the effect. Yeah, here's just some examples of oncogenes. Maybe you've heard of some of these. Yeah. When I look at the functions, I see growth factor, cell cycle regulator, regulation of transcription, all things involved in normal cell division and growth. And if those are screwed up, the cells go nuts. So an oncogene will cause, if it's activated, it will cause a cancer. It's kind of like putting the foot on the gas, kind of push it forward. Now, another way to get cancer is to take away the brake pedal. And so you just keep going forward. And that's how I think about it as a tumor suppressor gene. You've got genes that are the proofreaders that usually stop a cell that is defective. They stop it, they say, hey, you're done. Either try to repair it or you're done, cell, we're going to kill you. You start removing those brakes, and then the car just rolls down the hill. And so one of the most famous is P53. I think some of you guys have remember studying that. But in a cell cycle, you have checkpoints along the way that is where the DNA is checked, proofread, and cell division is stopped if there is a problem. But P53 is most important in that, the most important one. Tons of cancers have a mutation here. So if you screw up that protein, the cell doesn't proofread, it just goes. Yeah. I'll talk about the BRCA gene a little bit later on too in breast cancer. So this just to show this idea here that you've got some kind of carcinogen causing mutations, and normally it's going to cause some DNA damage, and so P53 is going to check it out. It's going to proofread it, and either the cell is going to go through senescence, means it just gets old and dies, or it's going to be checked and see if you can repair it, and that's cool. It can go on with its life. If not, it's just like, oh, this is too big of a mistake. It's just signal for apoptosis. And if the repair doesn't work, apoptosis. So you can see the end is cell death, or you can repair it. Well, without this P53, look at that. It just goes. They don't care. It just divides, and you end up with cells that have this mutation in them. All right, so you have these changes that are going to affect cell growth. And for instance, if you screw up an area where apoptosis is supposed to tell the cell to die and the cell ignores it, well, then those cells build up. They don't die. They're supposed to, like, okay, you're going to die, fine. And then like cells like, oh, screw that, I'm not going to die. And they builds up, and the other cells die, and you end up with this population that have that mutation. or you get immortal. Cells are not supposed to last forever, these cells. And one way, I don't want to get into it too much, but at the end of your DNA, you have telomeres. It's like this kind of, it's just junk. It's a bunch of repeated sequences. But each cell division, the telomere gets shorter and shorter. And usually cells have like a 50 divisions for a cell, you know. And the telomeres get shorter, but you can get a telomerase, you can get an enzyme that builds up that telomere each time. It builds it up. That cell becomes immortal. It does not keep getting shorter. So there's ways to do this so that the cells don't die. They're going to end up building up and making a tumor, because the normal cells will die. They have a lifespan. So I can't stress enough this multi-step, this ratcheting up. So the longer you live, your cells are exposed to mutations. And one mutation is not going to do it, two is not going to do it, but you keep exposing these cells, and eventually you're going to get to a point where the cell has these abilities to escape from its tumor, to make blood vessels grow to it, to live better with glycolysis, things like that, to avoid your immune system. So these mutations, it gives them characteristics that make them successful. And in something where it's inherited, you've already got that first hit because you're born. And so you get a cancer sooner usually, yeah. And cancers, yeah, it's complex. We're going to see it's why it's hard really to get a therapy, because everyone's journey, these cancer cells is different. Different mutations happen. And just an example, looking at this colon cancer. So it's adenocarcinoma here in the colon here. And yeah, the first hit is in this gene. And the cells actually look normal. You can look at it, the cells in the microscope, no problem at all. But additional mutations cause it to form a polyp. And this polyp itself is just, you know, it goes into the lumen of your colon, and it's not spreading anywhere. But then if you let it sit for 5, 10 years or a few years, you get more mutations that can allow it to break through the colon wall, and then it's in your bloodstream, goes to your liver, and it goes to your bones. So there's these multi-steps, and obviously if you catch the polyp during a colonoscopy, they can just remove it, and then it doesn't have that chance to become cancerous. That's why screening is so important. So yeah, like I say, your breast cancer is different than someone else's breast cancer because it may be using some of the same genes, but then your mutations are a random process. They happen at random places. And so it's really hard to get a therapy that works for everyone. It's got to be really tailored to you. And I like that these this cancer is little experiments in evolution. You have a whole population of cells, and you have the mutations happening. And here in my backyard, you know, different plants will have different variations, and the ones that aren't successful won't make it, but there'll be a few that are turned into weeds because they become very successful because of some of these changes that make them well suited for this environment. Just like cancer cells, you've got variation because mutations are different. Most of those will not make it, but there's a few, if they get just the right variations, that make them successful in your body. I mean, not contributing to your health and well-being. They're looking out for themselves, and they're successful. They don't have a mind. They divide. That's what cells do. And so if they're successful at that, they'll just keep dividing without thinking about you as a person. That's obvious, right? Yep. And so you'll see progression. It's ratcheting up, like I said, when the mutations will build on each other. All right, some things that cause cancer. What do we know? There's 4 things really, categories that we know. Chemicals, radiation, infectious agents, and genetic predisposition, right? So chemicals, all kinds of chemicals out there, benzene, and nitrates in our preserved foods. Cigarette smoke has benzene in it too, formaldehyde, all kinds of things. So lots of chemicals are carcinogens. Radiation, you get a whole bunch of X-rays, or you work in radioactive power plant, or UV radiation from sunlight, of course, cause skin cancer. Infectious agents, viruses especially. There's one bacteria we know about. I think I'll have a next slide. Yeah, this gets into more detail. So these carcinogens, yes, look at all these chemicals. So, and more are being discovered. Some of the cancers we see in the modern world, we often look for maybe chemical answers, the things we have in our environments. The chimney sweeps got a lot of scrotal cancer, and it was found out that this coal tar from their working, they must really get into their work there to get coal tar in their scrotum. But then we've even determined in the coal tar what the chemical was that causes this cancer. So it's an early known pinning it on a particular culprit. I know in my line of work, well, parasitologists used to leave formaldehyde open in their labs because it would kill if there are any eggs or any airborne kind of parasites. Now we know you're not supposed to be breathing formaldehyde. So you saw a lot of lung cancers in parasitologists early on that worked in labs with formaldehyde. And I worked with formaldehyde in my fingers, preserving tadpoles and such, and really should wear gloves, but at the time, actually deadened my fingers. I couldn't feel them for a while because it kind of preserved my fingers, came back. Yeah, I know better now. Indeed, I think I've covered everything there. And of course, the greatest source in today's world is smoking cigarettes, just filled with hundreds and hundreds of different chemicals, many of them known to cause cancer. And so you're just breathing this smoke into your lungs. It's not just lung cancer or laryngeal cancer. It causes bladder cancer, all these cancers, because the chemicals are absorbed into your bloodstream, and you're just assaulting your whole body. Some people all day, every day, unless they're sleeping, they're putting smoke into their bodies. It's really sad. And so the biggest contributor to carcinogens is smoking, definitely. And interestingly, too, hormones can be used. You see hormone treatments for cancer, and hormones can elicit cancer too. You have people in menopause, they get hormone replacement therapy, and it puts you at a higher risk of uterine cancer. So, and there's reasons for that. And then radiation. Here we're talking about X-rays or nuclear radiation or UV light from sunshine, right? It's dose dependent, definitely. Especially, you should know, for skin cancer, people like me who's got freckles and fair skin, and especially that they go out and burn, like get serious burns once in a while, really shown, as opposed to a darker skin person, less likely to get skin cancer. But you can be very dark and get skin cancer too. But definitely fair-skinned, white eyes is more likely to get that. And yeah, I have blue eyes versus brown eyes. There's a slight increase if you have cancer, if you have lighter iris of retinal cancer. So, yeah, this is Chernobyl, of course. Japan had the more recent nuclear power plant disaster, radiation going into the ocean, and yeah, after Hiroshima and Nagasaki in World War II, cancers. There's great evidence about radiation causing cancer. Finally, can microorganisms, can getting sick cause cancer? One bacteria, the one that causes ulcers, Helicobacter pylori, can cause gastric cancer. That is, the link has been shown there. Other than that, viruses. And again, you should know why. Viruses, what they do is insert DNA or RNA into your cells. And in some of them, the DNA goes into your DNA. And once you start fooling with your DNA, you know if it's in the wrong spot, you're going to cause cancer, right? And so the most understood one is with HPV. And that virus will grow and cause cervical cancers in many cases. So it's been well looked at. It's why you want to have a vaccine useful before you're sexually active for the high-risk HPV, which in the past would lead to cervical cancer. But that vaccine and also Pap test to test it, we're often, you can catch this. Cervical cancer has gone way down, those numbers. And of course, you can be genetically disposed. You can get your 23andMe results, and with it comes your predisposition to various genetic diseases, right? And then we look at all these diseases. Well, we're talking about cancer here. Looking at cancers that run in families. It doesn't mean you're going to get it, but it makes you more likely because you've kind of already got the beginnings of that. Yeah, most are rare, these familiar cancers. And even these cancers that cause breast cancers, like the BRCA gene, and I looked that up here. It's if you inherited this gene, there's a couple different types. Your chance of getting breast cancer and ovarian cancer is just huge, a large amount. So much so that people often get a prophylactic mastectomy, double mastectomy, just to remove the breast tissue. Angelina Jolie did this because chances sometimes I've heard even higher than this. If you had 80% chance you're going to get breast cancer, you just want to live with that fear and constant checking of it, or just remove the breast tissue and get implants, and then live your life without that worry. And so, that mutation. But when you look at breast cancers out there, you can see like 90% of them, there's not a problem with the BRCA gene. So just to put that in perspective, that there is this genetic disposition, but there's also other causes that may be just as common or more common. All right, natural history of cancer. So I think I've kind of spelled it out. That takes multiple genetic hits. All right, you quit smoking. You'll stop this ratcheting up of the mutations. In the early on mutations, silent. The cells don't look any different, but you started the process, and then who knows if the next hit is going to allow it to metastasize. And when you hear cellular atypia, that means the cells look atypical. That's when you start seeing differences in the cells. And so what does that mean? How can you recognize a cancerous cells? Well, it's what a pathologist that's a cytologist that looks at these cells do. They look at cells and they notice things about them that tell them that they're cancerous. So usually the nuclei is large with big nucleoli because they're really active in making proteins. They're actively dividing. So they're always in this kind of division. So big abnormal nucleus with multiple nucleoli. A lot of evidence of reproduction with little cytoplasm. So here you see progression, looking at the changes in the cells. The cells are rapidly dividing, so they're going to show evidence of that when you look at the cells. Now, dysplasia, are we going to get abnormal look to the cells? So you're going to see the cells, dysplasia means abnormal cells growing. So it doesn't necessarily mean that it's going to be malignant yet, but you're going to notice differences in cells. And so that's why when they take a polyp out from colon cancer, they take a biopsy of it, or they take a breast lump and do a biopsy of it to look at those cells, or cervical cells, take a look at it. And you'll hear low grade versus high grade is how different the tissue looks. Yeah, and you can have cells that are completely look really wrong, but if it's in situ, if it's not spreading, then removal of that will take care of it if they can do that. Yeah. So, how do you get cancer to begin to be malignant? Well, It's benign until it has developed the ability to spread, to invade nearby tissues, and then malignant means to travel distant places. Well, to metastasize. Metastasize means to move distant places. Malignant means it can spread into adjacent tissues. So you can see in this illustration here, you can see it's dysplasia. The cells are very abnormal. And you can see here, you can remove it at this point, but at this point, they've got the ability to burst through that basement membrane that all epithelial cells sit on, and then they can spread. Yep. And so they spread somewhere, and then they need to be able to find a place where they can flourish. They can tap into a blood supply, and they can grow, and they can evade your immune system from killing them too. And if it's just invasion, you should know the difference. Invasion is just spreading to nearby tissues. If you can cut it all out, then you can cure the cancer. It's all gone. But in many cases, it's widespread and you can't really cut it all out with damaging normal tissue. So then you've got to just work on chemotherapies, radiation kind of therapies. If it has metastasized, it means it's spread. And now it's all over different places, and that's not a good sign. So metastasizing, traveling to distant locations. Yeah. And so you want to prevent it ideally before this point, but you may not have any symptoms until it's too late. So I'm seeing this neoplasm breaking through the basement membrane here. I'm seeing it spread to a blood vessel, for instance, and then some of these will lodge somewhere else. They've got to leave the blood, and then it can grow in that location, in many, many locations. Yeah, this is from your book. It shows it very clearly. You can see it's become malignant. It's broken through that basement membrane, and then it's going to learn to metastasize, to move. It's got to make it into the blood vessel. And then at that point, a cancerous cell should be attacked by your immune system. And so, most of these don't make it. But if you have a group of them that can maybe be coated in platelets and maybe evade the immune system long enough to find a distant place where they can leave the blood vessel, and it's called intravasation and extravasation. They leave the blood vessel and then they find a home where they can establish themselves, get blood vessels to grow, to feed them, and then it's going to grow somewhere else. And so you can have numerous tumors growing in your body if it metastasizes like this. All right, you guys see the progression here, what needs to happen? Leave its original site. Blood vessel or lymphatic vessel, usually how it travels somewhere. Then it's got to leave the blood vessel and establish in its new home. All right, finally, prognosis and treatment. So you stage cancers, and different stages, usually using this method, the TNM. The tumor, N is for the lymph node, as it traveled to lymph nodes, and then whether it's metastasized or not. And so you can look here for colon cancer. When they look at the tumor, you can see there's the best to the worst, where it's gone all the way through the bowel wall. And here it's just in the submucosa, it's still contained. Lymph node characteristics, you can see it's traveled to 1 or traveled to 4 or more. So they grade these. All cancers have their own formula. And then is it metastasized from the colon to the liver, or has it not? So these things all go into a formula. Each cancer is different. But stage 1 is the earliest stage, and stage 4 is that means it's metastasized, and that's the worst prognosis. Ah. Looking at survival rates, you hear about 5-year survival rate or 10-year survival rate. That's what a patient wants to know, or sometimes they don't want to know, but it tells you about a way to plan your life, give you an idea of your chances. And of course, we get this data by looking at thousands and thousands of cases that are reported and seeing how long they live. So data is so important. These things are updated as we get more information. Yeah. So looking at colon cancer, you get in stage 1, 92% survival rate. At 5 years, 92% of people are going to be alive. They catch people at stage 4, 11% are going to make it to 5 years. So that's what the survival rate's about. And so cancers, since we know so much, I mean, it's so common, we know a lot about them. And so they're often very predictable. We know where to look. Well, we know risk factors. If you're a smoker, we know your risk factor for lung cancer is much greater. If you have breast cancer, we know where it's likely to spread next. So we can go look for the lymph nodes in your armpit are called sentinel lymph nodes. We look at those to see if it's spreading there. We also know breast cancer, colon cancer often goes to the liver and often will go to the brain. And for weird reasons we don't know, prostate cancer doesn't spread there. Cancers of the spleen and kidney, they usually in situ, they usually don't metastasize. So a lot of things we don't completely understand, but at least from our experience, we have some idea what's going to go on with your disease. In cancers, sometimes you go in because you feel a lump in your breast or you see an unusual mole. That's true. But in many cases, the elderly going to the doctor for treating their diabetes or something, and they get a nurse or someone will be able to note these things. Or you get a bone break. You realize, oh, the bone cancer has weakened the bone. Or again, you feel a lump in the breast. It's going to be the first indication. You can also grade a tumor. So you can put it in different stages. And a grader is how you hear about well-differentiated or poorly differentiated. So what's best is a well-differentiated means that it looks like the original tissue as much. Poorly differentiated means it's just dividing like crazy. It's really lost all pretenses of looking like a normal cell. It just divides like crazy. Yeah. And so you can look at, when you look at a tumor, you can stage it, or cancer, and then grade the tumor by taking a look at it, if you're an expert at that. Yep, so you get a diagnosis of cancer. Then they're going to take a look at what is the stage, what does the cancer look like, and determine, can it be removed surgically, or what are your options going to be, which are usually chemotherapy or radiation therapy. It depends on the stage of the disease, absolutely. Basically, the best thing is surgery. If you can remove the cancerous cells, you've removed the problem. Yeah, it's that simple. But it's not always simple to just remove the cancerous cells. Radiation works really well, and you can do it to a specific area, although it kills the other cells too, and can cause some bad side effects. And our chemotherapy generally just kills highly active dividing cells. So it also makes your hair fall out, gut problems, nausea, all these things, because those cells are also actively dividing. So again, we're working on better and better therapies that are more targeted than some of our chemotherapies we have today. Hormonal therapy. In some cases, the cells are still controlled by hormones, so you can control the hormones, you control the cancer growth. It doesn't kill it, but it can slow the growth. Yeah. And then you can read about more targeted therapies that are going, right after those cells, to identify the actual cancer cells that have a particular molecular signature, and if we could just target those. Some of these are being delivered via virus. Really fascinating, some of these things. That'll be for our future. And then all of you should know the term palliative care. That is where you just make the patient comfortable with pain meds, other medications and therapies, just to make them comfortable, because it's a terminal situation. If you have where it's metastasized throughout the body, and sometimes you can tell them just months, weeks to live. So palliative care to make their last days as comfortable as possible. So, screening and diagnosis of cancer. Usually, you notice it because of a palpable mass. You're doing a breast exam, or you feel a mass in your muscle or fat or anywhere. It's like, this is weird, right? Or something under your skin. That's usually how it's found. It could be systemic manifestations, where you're losing weight, you're anemic, and they find, oh, okay, you have leukemia or something like that. Or it could be weird hormone production. You see some cancers cause weird hormone productions, and you start males producing milk or different kind of hormonal effects. And now, and again, these are things that are they're detected, and you're brought in. You come in because you present these things. Nowadays, they often do an MRI for something else, and they discover this. So you could do a chest X-ray, an MRI, and discover cancers that way. Of course, you haven't had any symptoms yet. You didn't notice a lump, so that's often stumbled upon like that, which is good to catch it as early as can. So these masses, benign neoplasms, usually they've got kind of a capsule around them, as opposed to more malignant is kind of has a regular edge without a capsule. This you can see would be easier to spread. So benign, usually kind of contained, the lump will be kind of more symmetrical than asymmetrical. And the cells in there are not that unusual, as you see with a benign neoplasm. Malignant ones, they can grow large because they don't have a capsule around them. Usually you talk about moles, that one of the characteristics is of melanoma is a regular border. Yeah, and so you can find these malignant neoplasms that are growing quickly. Yeah. Cancer pain. We're talking about pain, chronic pain. One of them is cancer pain, which can be really debilitating. And it occurs because sometimes the nerves are involved. Cancer is pushing on the nerves. When you destroy tissue, chemicals are given off. Could be blocking a bile duct, something like that, or inflammation that the cancer is causing. Your cells are trying to fight it. You know that causes pain, right? So with cancer, there's often quite a bit of this chronic pain that you can't alleviate, unlike acute pain, which is shorter term. So it's definitely something to be dealt with. Not all cancers cause pain, but about, I think, over half of them will cause chronic pain. And the tumors themselves can obstruct passageways. Rarely blood vessels, but we're talking about bile duct can be obstructed and cause pancreatitis if the pancreas also empties out that duct. In the colon, if the cancer can constrict it and cause to dilate proximally to that constriction, can cause incredible abdominal pain. So sometimes the tumor just obstructs passageways. Bleeding is common with cancers, hemorrhaging. Definitely if there's an ulcerous kind of skin ulcer, that's going to cause it to bleed. Colon cancer, sometimes the first time you detect it is blood in the feces. Same thing with bladder cancer. You see bloody urine. It could be several things, but one thing could be bladder cancer, that it's growing inside your bladder and bleeding. And it's why cancers can make you anemic if you lose too much blood. And then bone fractures. The cancer can grow so much, and you don't notice it until it weakens the bone enough that you get a fracture when you shouldn't have gotten a fracture or that kind of a fall. Yeah. Yeah. So lung, breast, prostates will move to the bone often. Yeah. And then you have bone cancers themselves. There's some unusual ones. I collect skulls, and you see ones, or I have a tibia that has bone cancer in it. An infection. This is what often will kill a cancer patient is infection. If you have like ulcers and sores, that allows bacteria to get in that way. When you obstruct something, fluid will build up and bacteria will start growing in that. If you have cancer, often your immune system is compromised, either naturally, some kind of leukemia or lymphoma, or through chemotherapy or radiation. Destroys your bone marrow. So more likely to be infected. You're usually more immobile, so you don't get clear stuff from your lungs. Yeah, nutrition, not usually, you don't have a great appetite with cancer. Yeah, so infection, a very big problem caused by a cancer or its treatment. Anemic, as I mentioned. because there's hemorrhaging, or because you're, if it's a bone marrow issue, that's where you produce your red blood cells, or your blood cells are being destroyed too quickly. All going to cause anemia. Cachexia is a term that I don't use very often, but it is this wasting away. And you see this in people with other diseases, tuberculosis, things like that. But it's just you lose appetites, and the cancer itself is growing so actively, it's using your nutrition, and your inflammatory response is just causing a general wasting away of terminal cancer patients. And there can be some weird hormone stuff going on too. You guys know much about paraneoplastic syndrome. Fascinating, where cancers can screw up your immune system and cause antibodies that mimic releasing weight. You can produce hormones, and the immune system causes you to release hormones naturally. And some tumors that can grow, called ectopic tumors, places like in your lungs that secrete hormones, like cortisol, things like that. And so one of the causes of having too much cortisol, Cushing syndrome, is you could have a big adrenal gland, pituitary problem, or you can have tumors that are producing it other places in your body, in your leg, your lungs. So anyway, so paraneoplastic syndrome is cancer causes an altered immune system and can really screw up the hormones. And it's kind of a little bit bizarre. And you can have tumors of the endocrine glands. You have a tumor in your pituitary, can cause giganticism, too much growth hormone coming out, or a lot of other hormones, right? Or a thyroid cancer, make too much thyroid hormone. So your diagnosis, if you have a neoplasm cancer, usually diagnosis comes, like I say, you come in for something else and they notice the cancer, or it could be a bone break, or you notice a lump, right? And they will go ahead and usually do a biopsy. So they'll take a look, they'll do an MRI or a PET scan, whatever they need to do to determine the extent, how far the cancer has spread, what stage your tumors are in, and then they'll be able to give you a diagnosis and then look at the treatment options. So why don't we screen everybody all the time, right? Ideally, sure, but no. Incredibly expensive. Some of it's intrusive, and so that's not the way we're going to go. We look at risks, and if you come in and you smoked your whole life, and you've got some chest pain, you're going to get a chest scan. If you're a non-smoker, come in chest pain, they're less likely to do it for sure, because they know your probability is less than the smoker. So screening has to be able to detect the disease if it's present. Obviously, that makes it useful. And a false positive, right, means that you get a positive, like, oh, I have cancer, but you really don't. And a false negative means you have cancer, but the test doesn't catch it. So make sure you understand those. And interesting, like the Pap test for looking for cervical cancer, I read your book says 50% negative. But if you get it regularly, every year, even if you missed it one year, you get it the next. So you can see it's a slow growing cancer. So that's why you want to take it regularly, because there are those false negatives. And then, we should be able to screen everyone. Like I say, if you don't have health insurance, you're not going to go and say, I'm going to get that colonoscopy and spend thousands of dollars, right? So you have the people that don't have health insurance not getting screened for colon cancer, and those that have the money do. And so we take a look, we do studies on cancer, and we know that colon cancer occurs in later in age. So we say age 50, begin that. Mammograms, if you have a history, then earlier, some you guys' age want to get it. But normally we know it's a disease of later age, so maybe in your 40s is when we suggest it, only because to do it earlier is invasive, expensive, and the chances are very low that you have it. Yeah, you may say to yourself, I have a headache. I should really get an MRI done. MRI is thousands of dollars. There's only so many machines, and so no. You're going to get it if they have a very good reason to suspect something. And then some of the tests, like today's colonoscopy, is just a horrible preparation. People don't like to do it, so they don't do it. And then if you want to scan for lung cancer, a good idea to do that is with an X-ray or a CT scan. Well, guess what? Radiation gives you lung cancer. So you don't want to get it every day to get a screen, right? Even dental X-rays, they keep track of how many you get because those things are going to build up your chances of cancer. And interestingly, should we do a test if we have no treatment? Do you want to know? You know, and the example here is prostate cancer. And so we can test it pretty easily now, even with a blood test. But it turns out it grows really slowly. So even if you find out you have prostate cancer, for most people, it's not going to kill you. You're going to die of something else before it catches up to you. And the treatments are not good. Surgically, it's hard to get to. It often causes problems with urination and sexual function to get in there. And then, yeah, radiation and chemo, we got no really good tools to get rid of it. So should there be a lot of screening for something we can't really do anything about? It's one of those questions like, do you want to know if you're going to die if you can't do anything about it? All right. So how do you guys prevent neoplasms? Well, you can decrease your risk factors, right? Number one, if you smoke, stop smoking. I doubt this audience I'm talking to is a lot of smokers. I certainly hope not. If you are, you're probably uncomfortable, but I don't care. I don't care about you guys. So these are things that will make you more likely to have these neoplasms. And just to reiterate, your age, big, sex, even race. You see, prostate cancer hits Black men much harder than white men, and each one has its own individuality to it. Yeah, cigarette smoking, sexual behaviors, talking about here, HPV, too much alcohol consumption. Alcoholics will have esophageal cancer and stomach cancer. Yeah, obesity leads to greater breast cancer, colon cancer. And then, yeah, I loved a good barbecue, but apparently they're finding that char in the meat, although I like mine more rare, is causing stomach cancers and such. This person is smoking while suntanning, so yes, really trying to get neoplasms. So finally, the last slide. Guess what? You are dying. Yes, I'm talking to you. We are all dying. That is our ultimate fate. Our prognosis is death. So some cancers, sure, it could kill you, but you may die of something else before then, slow-growing cancers. And again, it's something like a pancreatic cancer or more rapid brain cancer. Prognosis is much shorter. So, oh, my neighbors. What is normally going to kill you from cancer? Normally, it's going to be, most common is infection. And as I mentioned, you usually, because of the therapies or the nature of cancer, it's lowering your immune system. And then you're not as mobile, you're not eating as well, and so could be hemorrhaging or sores that cause infection. So die of pneumonia, bacteremia, where bacteria has gone throughout your body. Just normal wasting, and then definitely hemorrhaging, metabolic. So that's the ultimate fates of what's going to kill you. With cancer, so the cancer itself, the neoplasms are not toxic to you, but they just take over your normal body functions. And if they grow fast enough, you are going to die of one of these reasons. All right, important lecture, right? Hopefully you get a better handle on what cancer is, neoplasms more generally. And all right, thanks you guys.